Hello, we are Melbourne, Mexico, and we are very happy to have the honor today of learning about neuromodulation and dysphagia. The topic of this webinar is can the brain learn to swallowing? The neuromodulation revolution in dysphagia rehabilitation from neuroplasticity to clinical practice with TMS and TDCS. So it's a true honor for us to welcome Professor Shaheen Hamdy, one of the world's leading authorities of neurogastroenterology, dysphagia, and neuromodulation. Professor Hamdy is a professor of neurogastroenterology at the University of Manchester and practices clinically at Salford Royal Hospital in United Kingdom. His work has been pioneering in demonstrating how the transcranial magnetic stimulation (TMS) and transcranial direct current stimulation (TDS) can harness neuroplasticity to promote the recovery of patients with dysphagia following neurological injuries. With over 2 decades of research and numerous scientific publications and regional recognition, his contribution have helped transform swallowing rehabilitation and brain neuromodulation from research to clinical practice. Professor Hamdy, it's a true privilege to have you with us. On behalf of Meren and the entire medical community joining us today, we extend a warm welcome and thank you for sharing your experience and knowledge with us. Before start, I want to thank you, Professor. So welcome, and we're waiting for your talk.
Well, great. Thank you, Roel, for that kind introduction. And thank you to the audience for listening to this discussion, this webinar. And as Raoul has said, this will focus on how the brain might relearn swallowing and the new era of neuromodulation in treating dysphagia as a form of rehabilitation. So as Raoul has mentioned, I hold a emeritus professor of neurogastroenterology position at the University of Manchester, but I'm also the chief scientific officer at the company for Genesis, which has an interest in stimulation-based devices to treat dysphagia. So I think it's important before we move into the neuromodulation technologies to just simply understand a little bit more about the causes of dysphagia, and particularly the neurogenic causes of dysphagia. And these include a number of diseases which are fairly significant. Stroke being the most common, but there's many other diseases as well, such as ALS, Parkinson's, brainstem stroke, myopathies, myasthenia gravis. And this is not an endless list, but it's important to recognize that all of these conditions result in brain dysfunction, which then lead to a swallowing problem. Much of the work that's been done with neuromodulation is focused on stroke. So for the vast majority of the talk, I'll be talking about how this model of stroke is used as the underlying cause of dysphagia, and that's what's being treated. It's also, I think, important for us to just remember that as it stands at the moment, our current techniques for managing dysphagia are a little bit limited. We have, after a bedside assessment or imaging modality, both compensatory and rehabilitation techniques. Compensatory is often divided into bolus modifications, behavioral maneuvers, and rehabilitation is often divided into stimulation techniques and pharmacological agents. And of course, today I'll be talking about stimulation techniques. When these fail, the only option is alternate feeding routes, which is obviously dissatisfying for both the patients and the carers, and something that we want to avoid. And the reason why this is important is because dysphagia after stroke and indeed after other forms of neurogenic dysphagia are associated with a significant number of complications, both in terms of aspiration pneumonia leading to chest infections. And as you can see from the panel on your left, there is a much higher rate of both the incidence of pneumonia if you aspirate, but also the frequency of which you might have that problem. It's not just a one-off, it can be multiple times that people with aspiration related stroke can develop pneumonia. And the consequence of this is also significant. As you can see from this unpublished data, there is a relative risk of dying of 2.7, which, as you can see from the Kaplan-Meier curves here, shows that there's a significant associated survival deficit. So by a year, so 300 days, you can already see that over 30% of patients have died, and over the course of 2 or 3 years, it even falls further down to around about 50% of patients. So a pretty poor outcome if you have dysphagia. So today, I'm going to talk mainly about neurostimulation techniques rather than pharmacostimulation techniques. And I will quickly discuss 3 techniques, initially pharyngeal electrical stimulation, and then focus on the non-invasive brain stimulation techniques such as transcranial magnetic stimulation, transcranial direct current stimulation, and just as a quick aside, cerebellar stimulation, which sits at the moment mainly within the transcranial magnetic stimulation area, but it sits slightly differently from cortical stimulation. One of the reasons why it's important to consider these neuromodulation techniques is that we believe that the reason why there is recovery after swallowing related dysphagia from disease such as stroke is that there is compensation in the brain. So this compensation, which can occur spontaneously over time, is mainly associated, as you can see from this slide, with changes occurring in the undamaged pathways. So in this particular patient, she had had a stroke, and you can just about make it out the dark patch on the left side of her brain. And if you consider over time how, as they recover, you see this massive increase in activity for the pharyngeal muscles in the undamaged pathway. And this is maintained at 3 months. So I think what's critical to note is that the compensation here is significantly associated with undamaged pathway changes. And critically, it could be possible to enhance this or artificially accelerate this by stimulation methods. And that's what we're going to focus on. So the first topic is pharyngeal stimulation. And this is a technique that's been around for over a decade. It is not available in some parts of the world, so South America, Central America, and some parts of Africa, etc. It's mainly being used in Europe and in the United States. And as you can see here, what it involves is a base station, which is connected to a catheter, which sits in the pharynx, passed either transnasally or transorally, and it houses electrodes that stimulate at a particular frequency and intensity to deliver input, afferent input, to the swallowing areas of the brain, and then that then leads on to changes which then can be associated with recovery. Here we see an example of the mapping associated with a healthy and a stroke-related subject, and this individual, both individuals in fact, have received a combination of a single dose of pharyngeal electrical stimulation. And what you can see is that after stimulation, so on the right-hand side, you can see that the activation associated with that stimulation has increased on both sides, but potentially more so in the dominant side of the swallowing system for the brain. And in the stroke patient, and the stroke here was on the left cortex, after that, you can see there's an increase in activity in the opposite side mainly, although it's occurring in both sides. So you can see this increase in activation, which is linked to changes associated with pharyngeal electrical stimulation. What this shows is the changes that was associated with pharyngeal stimulation in an active and a sham arm, single dose, 16 subjects randomized to active or sham. And you can basically see that the stimulation arm, which is actually all of the columns on the left, showed an improvement in swallowing function. Whereas in the active arm, in the sham arm, which is all the columns on the right, did not show any significant change. These should be color coded, but unfortunately, I think the slide has just come out slightly oddly. But nonetheless, it's important to recognize that these changes, which are pharyngeal transit time, swallow response time, and aspiration score, were all associated with an improvement, which was not seen in the sham arm. This was a correlation analysis, which has essentially looked at whether the changes in the swallowing activity, the improvement in aspiration score, was associated with increased brain changes. So the improvement in swallowing score is in the x-axis, and the change in brain function was on the y-axis. And you can see that as the brain activity was increased, so the swallowing scores associated with aspiration score were also improved. So we have some evidence that there is a correlation between brain excitability and improvement in function, which is important not only for pharyngeal stimulation, but also for the other techniques that I'm going to talk about. This is a meta-analysis of 3 studies that were done in the early stages of pharyngeal electrical stimulation. And I just want to highlight the fact that when you combine that data together, you can see that there was a significant improvement in penetration aspiration scale and in also the dysphagia severity rating scale, which is a score that gives you a functional score of swallowing function, 12 being worst, 0 being best. And what this shows is that the odds ratio and the significance for improvement in the penetration aspiration score at 2 weeks was significantly associated with pharyngeal stimulation, and the functional scores were also changed significantly. The effects on death and pneumonia were not particularly strong. The hospital discharge was trending, but it wasn't quite reaching there. But this is only, as you can see, 55 to 63 subjects. So we have some early data here in this independent patient meta-analysis. I think we can probably skip this slide as it's really about BDNF, and I don't think we're going to talk about genetics today. So the pharyngeal stimulation work has led on to a number of trials, one of which is Fast Track. And Fast Track was a randomized single-blinded pivotal superiority trial looking at the ability of pharyngeal stimulation to help in decannulation of tracheotomized stroke patients. And what this showed in the primary outcome, so patients received 3 days of 5 Hz stimulation within about 72 hours of the tracheotomy being placed. And you can see that the active arm here, which is on the left, had nearly a 50% change in ability to remove the cannula, whereas in the sham arm it was only around 10%, so there's a 40% difference. So a very significant effect that pharyngeal electrical stimulation was able to allow patients who were cannulated during tracheotomy to have that decannulation take place. This was another meta-analysis that was performed with pharyngeal electrical stimulation from Dysphagia 2024. And what you can see here is that there is an overall significant effect when you combine all the data, both PAS, voice, and DSRS. DSRS was highly significant, but nonetheless, the overall effect was in favor of pharyngeal electrical stimulation. So another meta-analysis that seemed to be supportive of the effect size. The same group also looked at the ability of pharyngeal stimulation to remove a nasogastric tube, and again, they found that there was a significant effect in favor of pharyngeal stimulation. So we have some data here, both in terms of functional scores, but also in terms of a behavioral aspect and removal of an NG tube, which is perhaps considered to be a little bit more objective, supportive of the role of pharyngeal stimulation. Interestingly, there are other approaches to pharyngeal stimulation. This was a group in China who've been looking at the effects of a modified version of pharyngeal electrical stimulation, where they deliver it with a slightly different stimulation pattern, but still 5 Hertz. And they just kept on delivering it until the patient reached a point of voice equals 3, which is the functional oral intake scale. And this scale runs from 1 to 6, with 6 being the best. And you can see that over the course of a few weeks, if they continue to keep on stimulating, then over 80% of the patients were reaching that functionally useful score. So an interesting study which suggests that in these more chronic patients, and these were more chronic, they were responding. So we're going to move on to transcranial magnetic stimulation, and specifically a subset of that, which is the technique of repetitive transcranial magnetic stimulation. Here we see an example of one of the devices. You can see here that the device is set up such that the coil is placed over the head in the right position, and that then the patient can then be seated appropriately, and then the stimulation can then be delivered, and ideally responses measured. So it's a new technique, and I'll explain a little bit more about it. What magnetic stimulation is using the Faraday's third law of electromagnetic induction. So this tells us that when there is a time-varying magnetic field, it can induce a flow of current in tissue. And in this case, if you place it over the motor cortex, you will excite the motor system. The advantage of this is that it is considered to be fairly painless, and that the stimulation can penetrate reasonably deep into the cortex, although it won't go into subcortical structures. The other aspect of this is that compared to electrical stimulation of the brain, which does exist, transcranial electrical stimulation, it's relatively safe, and electrical stimulation actually, unfortunately, does cause quite a lot of discomfort, so it's not really practical. What you can see here is that the technique of magnetic stimulation has been around for many years, over 3 decades. This was an old picture from Sheffield, actually, where they first developed the technique, and it's since become highly developed and has moved into different realms, including repetitive stimulation and also combining it with EEG. So it has moved on quite a bit since then. This is an example of one system. This is the MagStim system. You can see here that there are capacitors which hold the charge, and then when that charge is released through the coil, it creates that time-varying magnetic field, which induces the changes in the brain. And it usually can penetrate upwards of nearly 3 centimeters, but so you're not going to get into deep structures, but it is useful for definitely cortical stimulation. Here we see another example of the TMS system and the different types of coils that exist. The figure-8 coil at the top tends to produce more focal stimulation, whereas the circular coil, more diffuse stimulation. And this kind of more basket-style coil tends to penetrate deeply, usually into hemispheric fissure. So this tends to be used more for sort of leg work rather than arm work, but can be used to stimulate other structures such as the cerebellum. And the kit here, which I think is probably the Duomag system, is all fairly compact, and you can see it's on a trolley, so you can move it fairly easily to the patient. One of the things that's important about repetitive TMS is the general principles. One is that it will stimulate very repetitively, and most people would not go above 50 hertz. In general, high frequency is thought to be greater than 3 hertz, whereas low frequency tends to be more 1 hertz or less. And these frequencies tend to have different properties. High frequency tends to be excitatory, and low frequency tends to be inhibitory. But as I said, it's generally considered as a safe, as long as you stick to well-recognized criteria which have been given through a guideline that exists. So it tells us how much to give, how long to give it for, and which gaps to have in between. So some years ago, we looked at the effects of rTMS on brain function, and we looked at different frequencies. And what we found was that the 5 hertz rTMS was able to deliver, if you delivered it for around about 100 pulses, was able to increase excitability in the brain, as you can see from these MEPs, motor evoked potentials, for up to about an hour afterwards, whereas the sham didn't do anything. And if it was targeted to the pharynx, it didn't have any effects on the hand muscles either. This just shows you the group analysis and shows you that other frequencies that we looked at, 10 hertz, 1 hertz, and of course sham, did not have any effects, whereas the 5 hertz paradigm, 100 pulses, was able to sustain effects for up to an hour, and then it starts to fall off after 90 minutes. So that was just one dose. I think this is just repeating it again, so we don't need to talk about this. So the question is, with this dose, does a treatment like this work in patients with stroke who are dysphagic? And here's one study from 2012. It's from Jimwoo Park's group in Korea, and they took 18 stroke patients who were around about 1 month after stroke. They were dysphagic, and they were randomized to receive either an active or a sham 5 hertz rTMS treatment, 1 session a day for 10 days. And the treatment was applied to the contralesional cortex. So that's the normal cortex. They gave 500 pulses and set it at 90% of hand motor threshold, and their outcome measure was videofluoroscopy. And what you can see in panel A is the active arm, which showed that after 2 weeks, and then at 4 weeks, patients had generally improved, and that was significant compared to baseline. Whereas in the sham arm, you can see that it was pretty flat. So even at 2 weeks and 4 weeks, there was almost no change associated with the sham stimulation. So quite an interesting result. Here we see another meta-analysis performed by René Spire, which was published in 2022. And they looked at RCTs of rTMS for oropharyngeal dysphagia. And you can see that combining all the data together, which was around about 8 or 9 studies at the time, there was a significant overall effect in favor of the rTMS. So rTMS was significant, and in the main, these were all stroke-related patients. What is important is that it should be recognized that the rTMS effect can be variable at times. And this variability was something that we looked at for the swallowing system. So here we see around about 50 people who were studied with rTMS, and we looked at 1 hertz and 5 hertz. And generally what you can see here is that it's very variable. So not everybody excites and not everybody inhibits. So here we see the 1 Hertz paradigm, and we would expect most people to be inhibitory, but actually they were all over the place, and the red line is the mean, and it didn't really show a lot. With the 5 Hertz, again, we expected everybody to be excited, and there was a bit more excitation compared to the 1 Hertz, but overall it was not really as excitatory as we thought it would be. So again, this is quite significant, as variation may actually be important in terms of the recovery process when you deliver it as a treatment. So one way to get around this may be to consider using something called metaplasticity, which is the plasticity of plasticity. What this does is create a sort of negative feedback system to essentially prevent excessive excitation or inhibition. What tends to happen here is that there is a sort of dynamic threshold. So if you overexcite, you will not get more excitation, but you may get more inhibition, and vice versa. So this is the kind of concept. In the brain that is suppressed, if you deliver excitatory input, you will get quite a big bang for your buck. But if you give inhibitory input, you won't get much. Vice versa, if the brain is already excited and you try to excite it further, you get very little. But if you try to inhibit it, you get quite a significant amount of inhibition. So this is called metaplasticity, and it could be used potentially to enhance and take away some of that variability of the RTMS process. So what we did, and this was work done by Ivy Cheng and published in Journal of Physiology in 2020, we looked at different preconditioning. And in this case, we looked at the 5 Hertz preconditioning. So what the protocol was that we'd either deliver the sham 1 Hertz, which is normally excitatory, then a gap, and then the treatment, which is the 5 Hertz. And then in contrast, we delivered the real 1 Hertz, which is inhibitory, then a gap, in this case 30 minutes, and then delivered the 5 Hertz, with the expectation that there would be an interstimulus interval that would allow enhancement. And in the case of this study, you can see that 30 minutes gap between 1 Hertz followed by 5 Hertz was able to induce quite a significant increase in the MEPs. And here it's shown again in this chart. What you can see here is that compared to just delivering a sham preconditioned 5 Hertz interval where you didn't get huge effect, if you did the preconditioning with active 1 Hertz, so active 1 Hertz followed by a gap, followed by a 5 Hertz, there was a huge improvement, a huge response of about 150%. And this was highly significant. So what we can see here is that there is the opportunity for treatments that we may assume may not be very responsive to become responsive if you deliver an inhibitory followed by an excitatory input. So what about transcranial direct current stimulation, or TDCS? This is also a non-invasive brain stimulation. What it does is delivers a low intensity direct current, usually between 1 and 2 milliamps, to the cerebral cortex. The delivery uses skin surface electrodes, which can be placed on the scalp. And in the example you can see in the corner, you can see that newer technologies allow you to wear a special cap, which allows you to move the electrodes in different configurations. The core action does not trigger action potentials directly, and the function is generally a sort of sub-threshold modulation that shifts resting brain potential. There are other aspects to it. It's considered to be a non-invasive. It's relatively painless. Low amplitude current. The sham can be pretty good because it's hard to distinguish, and it will modulate cortical excitability. In some of the early work, so going back nearly 20 years, was able to improve hand function after stroke. And you can see in the panel one is able to adjust the configuration to optimize the type of TDCS that you want to get. Generally speaking, we try to position one electrode over the supraorbital ridge and the other electrode over the opposite hemisphere of the target. And that would be considered to be either a cathode or an anode configuration. So if you have a configuration where the cathode is in the supraorbital ridge and the anode is over the cortical area, you generally will get excitatory effects, and we call that anodal stimulation. If you reverse it, so the cathode is over the cortex and the anode is over the supraorbital ridge, then you will get inhibitory effects generally, and that's called cathodal stimulation. So anodal is generally excitatory, cathodal is generally inhibitory. There are some side effects associated with TDCS, some localized skin reactions, tingling, itching, maybe some redness. Some patients, some subjects may get minor headaches, perhaps even a bit of fatigue, but the recurring rates are similar to placebo. Rarely you might see skin burning, which is unusual, but that can happen. And there is this thing called phosphenes, which are visual flashes, which are occurring actually in the retina. And that can be a bit disconcerting, but it's pretty harmless. So what we would like to do is try and understand whether the TDCS also causes an increase in activity. And as I've mentioned already, one way of doing this is to understand whether it can change cortical excitability. And we can use a single pulse TMS, transcranial magnetic stimulation, to assess this. So we'll have a catheter in, electrodes placed in the pharynx, this time recording rather than stimulating. The stimulation is the magnetic stimulus that we place over the motor cortex, and we measure pharyngeal evoked potential, or EMG, and we can look at that as our surrogate marker for excitability. This is an example of one of the catheters we use to record the MEPs. You can see the ring electrodes on the catheter. So here we see an example of anodal stimulation on cortical excitability. And what you can see here is that we looked at different recipes. We looked at 10 minutes for 1 milliamp, 10 minutes of 1.5 milliamps, and 20 minutes of 1 milliamp. And this, as I said, is mainly anodal stimulation. So the 10 minutes, 1 amp, which is considered to be the standard, was not particularly effective. It didn't really change anything. Whereas when we looked at the 10 minutes at 1.5 milliamps or the 20 minutes at 1 milliamp, we were able to get distinct change in excitability, excitatory input to the brain. So it looks like you have to use a bit more juice to get your effects, but it does do something if you do it properly. There are other approaches that exist beyond TDCS. One of these is called transcranial alternating current stimulation. This is a sort of secondary technique which entrains neural oscillations and essentially runs at different frequencies, alpha, beta, and gamma. And you can see that these frequencies range from a sort of lowish frequency, 8 to 12 hertz, through to a highest frequency of 30 to 200 hertz. And again, this can change cortical motor function, which is another interesting phenomenon. There is also transcranial randomized stimulation, TRNS. It's a variant of TANS, and so this will deliver the stimulation using the full spectrum of frequencies randomly. And again, this can change cortical excitability. So we're getting these newer techniques which also work in a similar way to the TDCS, but have a different configuration in terms of the way in which it stimulates, TACS and TRNS. Do these techniques work in the pharyngeal system? We've had a look at this. We looked at a series of healthy participants and looked at these various inputs, so the alpha, beta, and gamma TACS, and the full spectrum tRNS, and had a sham intervention as well. We kept the intensity the same at 1.5 milliamps for 10 minutes. And as before, the MEPs, the pharyngeal motivating potentials, were our outcome measure, and the control was a hand MEP. So this is what we did. I think this was what I've just said, but importantly that we followed up for 15 minutes for over 2 hours to see what would happen to the brain. This is one example of the MEPs changing after 30 minutes after tRNS. And you can see that there is definitely an increase in the excitability. If we look at the overall effects of the TACS and the tRNS, what you can see here is that there are specific frequencies that seem to be more effective. And in particular, it appears to be the gamma TACS and the tRNS that increase cortical excitability, and the effect that lasts for at least 60 minutes. We did not find an effect with obviously sham, but we did not find an effect with the alpha or beta TACS. So it does look like you have to have very specific frequency TACS to get your effects, or use the random noise. One of the advantages of these techniques that I didn't mention is that they seem to be associated with less side effects compared to TDCS, possibly less tingling, and you don't seem to get the phosphenes either. We were interested to understand if the TDCS was able to translate into a clinical technique. And one way of doing this without moving into patients is to use a virtual lesion. So what is that? It's an experimental disruption of cerebral function, usually temporary, short-term, targeted, safe, established track record, and can generally be induced by either cooling, which is often done in animals, or RTMS 1 Hertz, as I mentioned in the earlier aspects of RTMS. So what we were interested in was developing a model where we looked to see if the 1 Hertz RTMS was able to change cortical excitability and behavior. And our behavioral measure was a swallowing reaction time. What you can see here is when we delivered the 1 Hertz stimulation, we were able to inhibit the motor potentials. And this is shown here in this group data. We were able to inhibit in this situation. And when we looked at the sort of reaction time to a stimulus, in this case the hand, and looked to see what would happen in terms of the behavior, we were also able to show a reduction in this performance. So the performance was affected as well. So we've developed the model. The 1 Hertz was able to inhibit the cortex and change the behavior subtly for around about 30 minutes to an hour. So then we asked the question, can the TDCS reverse this virtual lesion? And here we see an example of this. You have the lesioned hemisphere, the unlesioned hemisphere, and the thenar. And what you can see here is that when you look at the changes over time, by 60 minutes in the lesioned hemisphere after the TDCS, there was a bit of a change. So we did get something. But interestingly, when we applied it to the unlesioned hemisphere, we got a much bigger change, a much bigger reversal. So here we see the group data. So what the model was that we delivered, we did some baseline recordings, then we delivered the virtual lesion, then we delivered the TDCS, in this case, over the unlesioned side of the brain. And then we looked to see what happened over both sides. And basically what you can see here is that the active TDCS was, and also the well, over both hemispheres, either hemisphere, so active lesion or active unlesion, was able to reverse the cortical suppression, which is shown with the sham TDCS at the bottom here. So the solid lines are active and the broken lines are sham, and there was clearly a difference, and there was clearly some reversibility going on. What about the behavior? Well, also we were able to show that the active TDCS was able to reverse the behavioral response. So if we gave them sham, we got no change in that behavior. But if we gave them the active intervention, which is the TDCS, the challenge swallows were enhanced. In other words, we were able to change the behavior in a positive, favorable way. So going back to the studies, does TDCS work in subacute stroke? And this is one of the larger studies. It was done by Sonia Sundrup from Munster. 60 stroke patients. They delivered anodal TDCS to the unaffected pharyngeal motor cortex, 1 milliamp 20 minutes daily for 4 days. And they looked at the effects compared to a sham arm. So you can see in the sham group, there was significant improvement in their FED score, which is an endoscopic score of swallowing function. And they were also able to get a change in the voice compared to sham. But they didn't see a change in the DSRS, which is interestingly. So some evidence here that the TDCS was able to reverse or improve swallowing function in these subacute stroke patients if you did it for 4 days, 1 milliamp 20 minutes. TDCS has also been used in other neurogenic conditions. Here we see dysphagia following multiple sclerosis, and Dominika Restivo showed about 5-6 years ago that when you deliver 5 days of TDCS to the unilateral cortex with patients who've got brainstem involvement, that he was able to improve the penetration aspiration scale within approximately so there was an immediate effect, and then it's kind of lasted between 2 and 4 weeks. But it wasn't sustained, it seems. So some subtle improvements in multiple sclerosis. So going back to the meta-analyses, and the big question is how you should treat these patients, how you should deliver the TDCS or the RTMS. Which hemisphere should you choose? Here we see the meta-analyses of treating the ipsilesional, so that's the same size as the damage, contralesional, the opposite side to the damage, and bilateral stimulation. And what you can see is there's a bit of a hierarchy. So bilateral seems to produce probably the greatest effect, followed by contralesional, followed by ipsilesional. So if you're going to choose to stimulate one hemisphere, I would suggest treat the contralesional hemisphere. If you have the ability to treat both hemispheres, then go for bilateral. So those are probably going to give you the best results compared to ipsilateral stimulation. So we're going to finally move on to cerebellar stimulation. Cerebellum is recognized to be active during swallowing. It's actually quite a strong activation in the cerebellum. This is a PET study from some years ago showing that the cerebellum is quite active. Here's the brainstem, this is the cerebellum. And one can target the cerebellum with the RTMS system, if you want, by putting the coil in the correct position. So in this case, we were using neuronavigation to position the coil over the cerebellum, so we knew we were in the right place. So this is work that was done by Dipesh Vasant, and what he looked at was different frequencies of cerebellar stimulation, 1 hertz, 5 hertz, 10 hertz, and 20 hertz. And then there was also a sham intervention. And they were generally controlled for the amount of energy that was delivered. So what he found, and this was delivering the cerebellar stimulation to only one side of the cerebellum, one side, that 10 hertz cerebellar stimulation was superior to any other frequency in terms of increasing cortical excitability. And not only that, but there was a bit of a sort of relationship between the number of pulses and the effect. So it looked like the 250 pulses of cerebellar stimulation was as good as 500 pulses, and certainly superior to 50 and better than sham. So the recipe that we would recommend is 10 hertz, 250 pulses per session. We also looked at unilateral versus bilateral cerebellar stimulation, and what we found was that bilateral did produce a slightly stronger effect than unilateral. Unilateral did work, but bilateral seemed to work even better. So bilateral may be a better way of looking at cerebellar stimulation. Since then, some groups in China have looked at the effects of cerebellar stimulation on subacute infratentorial stroke, so that's brainstem stroke mainly. They use a basket coil style configuration of their RTMS to target the cerebellum. But they use the same recipe, the 250 pulses at 10 hertz. And here you can see their effect. And in the main, what they did was they looked at either bilateral or unilateral or sham. And there was, again, a hierarchical effect. So bilateral was the best for improving voice compared to unilateral compared to sham. And this was true for all of the measures, really. So it looks like, again, there's evidence of bilateral being effective. And this was in brainstem stroke. In another study, also done in China, this was again cerebral stimulation, brainstem stroke, and they also had 3 groups: bilateral, unilateral, and sham. Again, they used the 10 hertz 250 pulse paradigm, and they delivered it for a total of 2 weeks, once a day. And here are the results, and you can see that the bilateral again produced a good result, reduction in the PAS. And they also had a separate sort of Sorling score called the FDS, which I think is lower is generally better. So as you can see here, bilateral was good, but so was unilateral compared to their sham. So definitely evidence of both unilateral and bilateral cerebellar stimulation being a useful adjunct to brainstem stroke, which are notoriously difficult patient group to treat when you're talking about dysphagia. Here we see a meta-analysis of some of the studies that have been done over time, done by Liu in 2024. And again, what you can see here is that when you combine all of the data, the 2-week data, 4-week data, there seems to be good evidence that cerebellar stimulation, looking at penetration aspiration outcomes, showed a significant effect in favor of the treatment. So we may be looking at the future for cerebellar stimulation. So I'd like to conclude. I've gone through a lot of information in this webinar, and hopefully you will have followed me. But I'd like to sort of just focus on the final point. Dysphagia is common, especially neurogenic, and especially with post-stroke dysphagia. The management of this condition can be tricky. There's some controversial evidence regarding standard treatments. And to be honest, with standard treatments, there's very little multi-center RCT level 1 evidence. The good news is that there are a number of emerging neurostimulation technologies now being applied clinically. And we think that they probably work by driving changes in the cortex, which will encourage or at least accelerate spontaneous reorganization after neurological injury. And I showed you that that seems to be one of the reasons why these patients recover spontaneously in natural recovery. And finally, that pharyngeal electrical stimulation, RTMS and TDCS, do hold definite promise in trials of dysphagic stroke. It's important to recognize that the non-invasive breast stimulation techniques are currently not directly approved for dysphagia treatment, but that may come through in the future. So I'd like to finish off there, and I'd like to thank everybody for listening. And I'm sure that once this webinar is completed, there may be some questions which may be filtered back to me to answer. I'll hand back to Raul for final comments. Thank you, Raul.
Thank you very much, Shaheen. So thank you for your valuable presentation and your enormous scientific contribution to neuromodulation and dysphagia. At Medtrain, we remain committed to continuing medical education and to bringing innovative technologies backed by scientific evidence to you. Thank you for your participation, and we wish you a wonderful afternoon and hope to see you very soon. So very, very, very grateful to be here with you. So thank you very much.
Thank you, Raul. It's a pleasure.
Thank you.